Wow, simulation 5, halfway to 10. Read the command first, scan the clues, build the differential, lock and move. 20 questions, 30 minutes. Clock starts now. Read the command, molecular basis. Recurrent pain crises, dactylitis, hemolytic anemia, sickle cells, howl, jolly bodies, HBS on electrophoresis. Sickle cell disease. Sickle cell disease is caused by a single point mutation in the beta globin gene, a substitution of valine for glutamate at position 6 of the beta chain. This swaps a hydrophilic amino acid for a hydrophobic one. When deoxygenated, the mutant hemoglobin S polymerizes into rigid fibers that deform the red cell into a sickle shape. Sickled cells occlude small vessels, causing painful vaso-occlusive crises and dactylitis, and they hemolyze, causing the anemia and jaundice. The Howl Jolly bodies signal functional asplenia from repeated squenic infarction. Choice A, alpha globin deletion, is alpha thalassemia. Choice C, absent beta globin, is beta thalassemia. Choice D, spectrin defect, is hereditary spherocytosis. The glutamate 2 valine substitution at beta 6 is the defining lesion of sickle cell. Howl, Jolly bodies plus asplenia raise infection risk from encapsulated organisms. Read the command, which principle? Increasing in diastolic volume preload raises stroke volume at constant contractility. The Frank-Starling mechanism. The Frank-Starling relationship states that within physiologic limits, the more the ventricle is filled during diastole, the greater the end diastolic volume or preload, the greater the force of contraction and the stroke volume. The mechanism is length-dependent activation, stretching the sarcomere toward its optimal length increases the sensitivity of the contractile apparatus to calcium and improves actin-myosin overlap. This lets the heart match its output to venous return beat by beat. Beyond the optimum, overstretching reduces overlap and the curve plateaus or falls. This is distinct from contractility, which shifts the entire curve up or down independent of preload. The Bowditch effect is rate-dependent force frequency. Laplace's law relates wall tension to pressure and radius. The defining feature here, stroke volume rising with filling at constant contractility, is Frank-Starling. Read the command, which condition? Ashkenazi infant, neurodegeneration, cherry red spot, exaggerated statal, NO hepatosplenomegaly, hexosaminidase, A deficiency, GM2 accumulation, Tay-Sachs disease. Tay-Sachs disease is a lysosomal storage disease caused by deficiency of hexosaminidase A. Without this enzyme, GM2 ganglioside accumulates in neurons, causing progressive neurodegeneration, loss of motor milestones, weakness, an exaggerated startle response to sound, and the classic cherry red spot at the macula. The single most useful discriminator on the exam is the absence of hepatosplenomegaly. That separates Tay-Sachs from Niemann-Pick, which presents almost identically but with hepatosplenomegaly. Niemann-Pick choice A is sphingomyelinase deficiency, also has a cherry red spot, but DOS have hepatosplenomegaly. Gaucher disease choice C is glucocerebrosidase deficiency with hepatosplenomegaly and crumpled tissue paper. Macrophages Tay, CX no hepatosplenomegaly, and hexosaminidase A. Read the command, which artery? Atrial fibrillation, embolic source, right face and arm weakness, greater than leg, sensory loss, non-fluent aphasia with intact comprehension, left middle cerebral artery stroke. The middle cerebral artery supplies the lateral cortex, which contains the face and upper limb regions of the motor and sensory homunculus, plus the language areas in the dominant, usually left hemisphere. A left MCA occlusion, therefore, causes contralateral right face and arm weakness, greater than the leg, contralateral sensory loss, and aphasia. The non-fluent Broca aphasia with intact comprehension localizes to the inferior frontal lobe in the MCA territory. The eyes deviate toward the side of the lesion. The patient looks at the lesion. The key contrast is the anterior cerebral artery, choice A, which supplies the medial cortex and causes LEG weakness greater than the arm and face, the opposite homuncular pattern. Atrial fibrillation is the embolic source. Face and arm over leg plus aphasia point squarely to the MCA. Read the command. Primary mechanism of injury. Epigastric pain to the back, heavy alcohol, markedly elevated lipase, hypocalcemia, acute pancreatitis. Acute pancreatitis is fundamentally a disease of autodigestion. Normally, the pancreas secretes digestive enzymes as inactive zymogens, activated only in the duodenum. In pancreatitis, most often from gallstones or alcohol, these enzymes are activated prematurely, which in the pancreas. Trypsinogen converts to trypsin inside the gland, which then activates the entire cascade. The activated enzymes digest the pancreas itself and surrounding tissue. Proteases cause necrosis and lipases cause fat necrosis. The fat necrosis binds calcium, forming soaps, which is why serum calcium falls, a marker of severity. Lipase is more specific than amylase for the diagnosis. The hypocalcemia comes from calcium saponification in areas of fat necrosis. The top two causes remain gallstones and alcohol. Remember, I get smashed. The defining mechanism is premature enzyme activation and autodigestion, not infection or ischemia. Read the command, which cells release the enzyme and the stimulus. Reduced renal perfusion triggers renin release, starting the renin-angiotensin-aldosterone system. The enzyme is renin, released by the juxtaglomerular cells, specialized smooth muscle cells in the wall of the afferent arteriole. The main stimulus is a fall in renal perfusion pressure, sensed directly as decreased stretch of the afferent arteriole, which happens here because of low cardiac output. Renin cleaves angiotensinogen to angiotensin 1, which ACE converts to angiotensin 2. Angiotensin 2 causes vasoconstriction, stimulates aldosterone, sodium reabsorption, and increases ADH and thirst, all raising blood pressure and volume. The three triggers for renin release are decreased renal perfusion, the JG cells, decreased sodium delivery to the macula densa, and increased sympathetic tone via beta-1 receptors. The macula densa choice A senses sodium and signals the JG cells, but the JG cells are what actually secrete renin. Low perfusion plus heart failure points to the JG cell mechanism. Read the command, mechanism explaining both the antihypertensive effect and the cough. Lisinopril is an ACE inhibitor, renoprotective in diabetes. Dry cough is the classic side effect. ACE inhibitors block angiotensin converting enzyme. This has two consequences that the question links. First, less angiotensin 2 means less vasoconstriction and less aldosterone, lowering blood pressure, and dilation of the efferent arteriole, which reduces intraglomerular pressure and is renoprotective, explaining the falling albuminuria in this diabetic. Second, ACE is the same enzyme that normally degrades bradykinin. Inhibiting ACE lets bradykinin accumulate, and bradykinin causes the dry cough, and rarely angioedema. The bradykinin mechanism is the elegant link one enzyme, two effects. If a patient cannot tolerate the cough, switch to an ARB, which blocks the angiotensin 2 receptor directly and does not raise bradykinin, so no cough. AC inhibitors are first line in diabetic nephropathy for that renoprotective efferent arteriolar effect. Read the command. Cell of origin of the diagnostic cell. Painless lymphadenopathy. B symptoms: alcohol-induced pain, ALI binucleate cells. Read Sternberg cells of Hodgkin lymphoma. The diagnostic cell is the Reed-Sternberg cell, a large cell with two mirror image nuclei, each containing a prominent eosinophilic nucleolus, giving the classic owl-eye appearance. Reed-Sternberg cells are derived from germinal center B lymphocytes that have lost their typical B cell surface markers. They are positive for CD15 and CD30. Importantly, the Reed-Sternberg cells are the minority of the tumor mass. Most of the node is a reactive infiltrate of lymphocytes, eosinophils, and plasma cells recruited by cytokines the RS cells secrete. Hodgkin lymphoma spreads in a contiguous, orderly fashion from one nodal group to the next, has a bimodal H distribution, and is associated with EBV. The alcohol-induced nodal pain is a classic if uncommon clue. The owl-eye read. Sternberg cell of B-cell origin is the answer. Read the command. Mechanism of SHAR. Menstruating, tampon use, fever, diffuse, rash with desquamation, hypotension, gram-positive cocci in clusters, Staphylococcus aureus, toxic shock syndrome. Toxic shock syndrome is caused by TSST1, a superantigen produced by Staphylococcus aureus. A superantigen bypasses the normal specificity of antigen presentation. Instead of fitting into the antigen groove, it cross-links the MHC class II molecule on antigen-presenting cells directly to the variable beta region of the T cell receptor, outside the peptide binding site. This non-specifically activates a huge fraction of T cells at once, up to 20%, triggering a massive release of cytokines like IL-2, IL-1, and TNF. The cytokine storm produces fever, the diffuse erythematous rash with desquamation, capillary leak, and hypotensive shock. Blood cultures are often negative because the disease is toxin-mediated, not bacteremic. Choice A, endotoxin LPS, is the mechanism for gram-negative sepsis, but Staph is gram-positive and uses an exotoxin superantigen. Streptococcus biogenes can cause a similar TSS via its own superantigens. The superantigen mechanism is the answer. Read the command. Which structure is cell B? Cell B has no stable resting potential, spontaneous phase 4 depolarization, and a calcium-driven upstroke, pacemaker cells, the SA node. Cell B is a pacemaker cell, the sinoatrial node. Pacemaker cells have three defining features. First, no true resting membrane potential, they slowly drift upward. Second, a spontaneous phase 4 depolarization driven by the funny current, a slow sodium influx, which gives them automaticity. Third, the upstroke of the action potential, phase 0, is driven by calcium influx through L-type channels, not sodium, which makes it slower than in working myocardium. This automaticity makes the SA node the natural pacemaker of the heart. Cell A, with a stable resting potential, fast sodium-driven upstroke, and a long calcium plateau, is a ventricular myocyte or atrial myocyte or Purkinje fiber, fast response cells. The discriminating feature is the upstroke ion, sodium for working myocardium, calcium for nodal pacemaker tissue. The SA node's spontaneous phase 4 is what sets the heart rate. Read the command. Underlying defect: fever, neurologic changes, renal involvement, thrombocytopenia, microangiopathic hemolysis with schistocytes, normal PT-PTT, deficient metalloprotease, thrombotic thrombocytopenic purpura. TTP is caused by deficiency or autoimmune inhibition of ADAMTS13, the metalloprotease that normally cleaves on Willebrand factor multimers into smaller pieces. Without it, ultra-large VWF multimers accumulate and spontaneously bind platelets, forming microthrombi throughout the small vessels. These platelet-rich thrombi consume platelets, thrombocytopenia, and shear-passing red cells into schistocytes, microangiopathic hemolyts, and shear-passing red cells into schistocytes, microangiopathic hemolytic anemia. The microthrombi obstruct flow to the brain and kidney, producing the classic pentad, thrombocytopenia, microangiopathic hemolysis, neurologic changes, renal dysfunction, and fever. The crucial clue separating TTP from DIG is that PT and PTT are normal in TTP. The coagulation cascade is not consumed. This is a platelet VWF problem, not a clotting factor problem. In DIG, choice D, PT and PTT are prolonged and fibrinogen is low. Treat TTP with plasma exchange and do not give platelets, which fuels the thrombi. Read the command, which nerve was injured, fibular neck fracture, foot drop, loss of dorsiflexion and eversion, high stepping gait, sensory loss over dorsum of foot and lateral leg, common peroneal nerve. The common peroneal fibula nerve wraps around the neck of the fibula where it is very superficial and easily injured by a fracture, a tight cast, or prolonged leg crossing. It divides into deep and superficial branches. The deep peroneal nerve controls dorsiflexion tibialis anterior and supplies the web space between the first two toes. The superficial peroneal nerve controls eversion and supplies the dorsum of the foot. Injury to the common peroneal nerve therefore knocks out both dorsiflexion and eversion, producing foot drop, with sensory loss over the dorsum of the foot and lateral leg. Use the mnemonic PED. Peroneal everts and dorsiflexus. Loss causes foot drop. Contrast with the tibial nerve, choice A, TIP, tibial inverts and plantar flexus. Its injury causes loss of plantar flexion and inversion. The fibular neck location plus foot drop is specific for the common peroneal nerve. Read the command, appropriate measure and value. Case control study of a rare cancer. The proper measure is the odds ratio, not relative risk. In a case control study, you start with diseased and non-diseased groups and look backward at exposure, so you cannot calculate incidence or relative risk directly. The correct measure is the odds ratio. Build the 2x2 table. Among cases, 80 exposed, 120 unexposed. Among controls, 40 exposed, 160 unexposed. The odds ratio is the cross product, 80 times 160 divided by 120 times 40. That is 12,800 divided by 4,800, which is about 2.7. The odds ratio of 2.7 means the cancer cases had about 2.7 times the odds of exposure compared with controls. For a rare disease, the odds ratio approximates the relative risk. Relative risk itself, choice A, requires a cohort or trial design where you can measure incidence. It cannot be computed from a case control study. Case control means odds ratio. Read the command. Which enzyme is deficient? Neonatal hyperammonemia after protein feeds, respiratory alkalosis, elevated orotic acid, no megaloblastic anemia, X-linked, ornithine transcarbamylase deficiency. Ornithine transcarbamylase deficiency is the most common urea cycle disorder and the only one that is X-linked. OTC normally combines carbamoyl phosphate with ornithine inside the mitochondria. When OTC is deficient, the cycle is blocked. ammonia accumulates, causing hyperammonemia, lethargy, and the respiratory alkalosis of central hyperventilation. Meanwhile, the unused carbamoyl phosphate spills out of the mitochondria into the cytoplasm and is diverted into the pyrimidine synthesis pathway, generating excess orotic acid. The single best discriminator is the combination elevated orotic acid without megaloblastic anemia points to OTC deficiency. In contrast, orotic aciduria from a UMP synthase defect choice DDoS cause megaloblastic anemia and has hyperammonemia, so orotic acid plus high ammonia minus anemia equals OTC. The X-linked inheritance confirms it. Read the command, mechanism of the polycythemia, flank mass, hematuria, left varicocele that does not decompress, renal vein invasion, perineoplastic polycythemia, and hypercalcemia, renal cell carcinoma. Renal cell carcinoma is famous for perineoplastic syndromes because the tumor cells ectopically secrete hormones. The polycythemia results from ectopic erythropoietin production by the tumor. EPO drives the marrow to overproduce red cells. RCC can also secrete PTA3P, causing hypercalcemia, and renin, causing hypertension. It arises from the proximal tubule epithelium, classically with clear cytoplasm, and is associated with von Hippel-Lindau gene loss. It characteristically invades the renal vein and can extend up the IVC. The new left varicocele that does not decompress when supine is a classic clue. The left gonadal vein drains into the left renal vein, so a tumor obstructing the renal vein blocks gonadal venous drainage. Each perineoplastic effect has its own hormone. For polycythemia specifically, it is ectopic erythropoietin. Read the command. Which interpretation is correct? Patient X, low FEV, 1 FEC ratio, high TLC and RV, obstructive. Patient Y, high FEV, 1 FEC ratio, low TLC and FEC, restrictive. Restrictive. The FEV1 FEC ratio is the master discriminator. In obstructive disease, asthma, COPD, emphysema, airflow out is limited, so FEV1 falls more than FEC, dropping the ratio below 0.7D. Air gets trapped, so total lung capacity and residual volume in series. That is patient X. In restrictive disease, pulmonary fibrosis, sarcoidosis, chest wall disease, the lungs cannot expand, so all volumes fall. FVC and TLC drop, but FEV1 drops proportionally or less, so the ratio is normal or even INC increased above 0.7D. That is patient Y. So patient X with the low ratio and air trapping is obstructive. Patient Y with the high ratio and small lungs is restrictive. The counterintuitive point students miss. Restrictive disease has a normal or HIH-EFE1 FVC ratio because both numerator and denominator shrink together. Use the ratio first, then the volumes confirm. Read the command. Which risk factor most directly contributes? Chronic hepatitis B, cirrhosis, nodular liver, very high AFP, arterially enhancing mass with washout, hepatocellular carcinoma. Hepatocellular carcinoma arises most often on a background of chronic liver injury and cirrhosis. In this patient, chronic hepatitis B is the direct driver. HBV contributes in two ways. It integrates into the host genome and can directly activate oncogenes, and it causes chronic inflammation with repeated cycles of hepatocyte death and regeneration. Each round of regeneration accumulates DNA damage and mutations, eventually producing malignant transformation. Cirrhosis from any cause is the common final pathway. Alpha-fetoprotein is the classic tumor marker, while aflatoxin from Aspergillus choice A is a real HCC risk factor that causes a specific p53 mutation. This patient's stated history is chronic HBV and cirrhosis, the most direct contributor here. The arterial enhancement with washout plus a high AFP in a cirrhotic patient is essentially diagnostic of HCC. Read the command, mechanism of toxicity and prevention. Cyclophosphamide causing hemorrhagic cystitis. The culprit is the metabolite acrolein, prevented by MESNA. Cyclophosphamide is an alkylating agent that cross-links DNA to kill tumor cells, but it is metabolized in the liver to several products, one of which is acrolein. Acrolein is excreted in the urine and is directly toxic to the bladder urothelium, causing hemorrhagic cystitis, bladder mucosal hemorrhage, edema, hematuria, and suprapubic pain. Prevention is two-pronged, aggressive hydration to dilute and flush the urine, and MESNA. MESNA 2. Mercaptoethane sulfonate binds and inactivates acrolein in the urinary tract, neutralizing it before it can damage the bladder. The key associations to lock-in, cyclophosphamide and ifosfamide cause hemorrhagic cystitis via acrolein, prevented by MESNA. Leucovorin rescues methotrexate. Dexrazoxane protects against doxorubicin cardiotoxicity. Allopurinol prevents tumor lysis. Match the protective agent to the specific toxicity. Here, MESNA for acrolein. Read the command. Which testing statement is correct? Painless indurated genital ulcer, chancre, non-tender lymphadenopathy, motile spirochetes on dark field, primary syphilis, treponema pallidum. The painless chancre with an indurated clean base, appearing weeks after exposure, is primary syphilis caused by treponema pallidum. Treponema cannot be grown on standard culture media and is too thin to see on gram stain. It is visualized by dark field microscopy or detected serologically. Serologic testing is two-tiered. Non-treponemal tests, VDRL and RPR, are inexpensive and used for screening and to follow treatment response, since their titers fall after cure. Treponemal tests, FDA, ABS, are more specific and used to confirm a positive screen. They stay positive for life. Remember, non-treponemal tests can give false positives. The VDRL false positives, viruses, drugs, rheumatic fever, lupus, leprosy, Lyme, pregnancy. That is exactly why a positive screen must be confirmed with a specific treponemal test. The painless indurated chancre with dark field spirochetes is classic primary syphilis. Treat with penicillin. Read the command. Underlying defect. Recurrent catalase. Positive infections, abnormal DHR and nitroblue tetrazoleum tests, chronic granulomatous disease, and NADPH oxidase defect. Chronic granulomatous disease is caused by a defect in NADPH oxidase, the enzyme phagocytes use to generate the respiratory burst. Normally, NADPH oxidase produces superoxide, which is converted to hydrogen peroxide and other reactive oxygen species that kill ingested microbes. Without it, phagocytes can engulf organisms, but cannot kill them. Patients are especially vulnerable to catalase positive organisms, Staph aureus, Serratia, Burkholderia, Nocardia, Aspergillus, because catalase positive microbes destroy their own hydrogen peroxide, denying the phagocyte even that backup source. The diagnostic tests confirm it. The dihydrohodamine flow cytometry test shows failure to fluoresce, and the older nitroblue tetrazoleum test fails to turn blue. Both indicate the absent oxidative burst. Choice E, leukocyte adhesion deficiency, presents with delayed umbilical cord separation and no pus, a different mechanism. The catalase positive pattern with abnormal DHR is specific for CGD. Block 5 is done. Let's review the 5 biggest traps from this block. Trap 1, Te. Sachs versus Niemann-Pick. Both have a cherry red macular spot. The discriminator is the organs, Tay-Sachs has NO hepatosplenomegaly, Niemann-Pick does. One word separates them. Trap 2, TTP versus DIS. Both have schistocytes and low platelets, but TTP has normal coagulation times because it is a platelet VWF problem. DIS consumes clotting factors, so PT and PTT are prolonged, and never transfuse platelets in TTP. Trap 3, restrictive lung disease. Students expect a low ratio because the lungs are sick, but the FEV1-FVC ratio is normal or even high because both values shrink together. Only obstructive disease lowers the ratio. Trap 4, elevated orotic acid. With hyperammonemia and no anemia, it is OTC deficiency, a urea cycle disorder. With megaloblastic anemia and no hyperammonemia, it is orotic aciduria from UMP synthase deficiency. The ammonia and the anemia tell them apart. Trap 5, chronic granulomatous disease. Recurrent infections with catalase-positive organisms point to an NADPH oxidase defect. The dihydrohodamine test confirms the absent respiratory burst. Train process, not memorization. 5 blocks down, 100 questions of pattern recognition built. StepLogic, learn how to think, not memorize.